Hi, everyone. Hope you guys are ready for a fun and thrilling podcast today. Today, we'll be covering Chapter 14 in our Neuroscience Fundamentals for Rehabilitation book by Lundy-Ekman. We'll walk through the upper motor neuron system and motor control. So let's talk about how it shapes movement, what happens when it's injured, and why this matters for conditions like stroke, spinal cord injury, and cerebral palsy. I'll start with how the brain organizes movements, move into other major descending pathways, and then cover upper motor neuron syndrome signs, and finish with clinical implications for rehab. So let's start with how the central motor system is organized. Lower motor neurons are the final pathway to muscle, but they're constantly influenced by signals coming down from the brain and signals coming up from the body. Upper motor neurons send descending commands, while sensory input, the cerebellum, and basal ganglia all modify those commands. So movement is a result of continuous negotiation between sensation, planning, and descending control. Upper motor neurons fall into functional systems based on what they control. You have your medial upper motor neuron system, which controls posture and gross movement. These pathways will help stabilize the body and produce automatic movements. The key tracks here include reticulospinal tracts for posture and gross limb movement, vestibulospinal tracts for balance and head position, medial corticospinal tracts for trunk and proximal limb muscles. These systems act quickly and often before conscious awareness, like turning your head towards a loud sound. The lateral corticospinal tract covers selective motor control. This is a precision system. It allows you to move individual fingers or isolate joint movements. The lateral corticospinal tract targets distal limb muscles, activates inhibitory circuits to prevent unwanted muscle activity, and is critical for fine hand function. The loss of this tract leads to abnormal synergies and poor fractionated movement. Then we have nonspecific upper motor neuron pathways, which contribute to global arousal. Tracts from the locus coeruleus and the raphe nuclei increase overall spinal excitability, especially during stress or emotion. This can make movement less precise when someone is anxious or highly aroused. Well, now we have our cortical brainstem pathway, which controls the muscle of the face, tongue, pharynx, larynx, and some neck muscles. They're essential for speech, swallowing, facial expression, and head control. Let's dig into our cortical motor areas. The primary motor cortex produces voluntary movement with a contralateral body map called the homunculus. The premotor and supplementary motor areas plan and prepare movement sequences. So let's start discussing our upper motor neuron syndromes. Upper motor neuron lesions can both cause loss of function and gain of function signs, and patients could show both over time. As far as loss of function signs, we have weakness and paralysis. If you have paresis, this means a partial loss of strength. If you have paralysis, this is a complete loss of voluntary movement. Terms like hemiplegia, paraplegia, and tetraplegia can describe the distribution of the weakness and paralysis. A loss of selective motor control can be contributed by damage to the lateral corticospinal tract, which reduces the ability to move muscles independently, especially noticeable in the hand. Acute upper motor neuron injuries can cause temporary flaccidity or hypotonia due to spinal or cerebellar shock, where lower motor neurons temporarily lose descending facilitation. Now we have our gain of function signs, which is hypertonia, spasticity, and abnormal reflexes. For hypertonia, we have two main types: spasticity, which is a velocity-dependent resistance to stretch, and rigidity, which is resistance that does not depend on speed. Spasticity mechanisms are going to be coming from two different contributors: myoplasticity, structural muscle changes like contracture, atrophy, and weak cross-bridge binding, and neuromuscular activity, which is hyperreflexia and excessive brainstem drive. For abnormal reflexes, some common upper motor neuron findings include hyperreflexia, clonus, clasp knife response, and Babinski sign. In terms of abnormal muscle coordination, you have abnormal synergies and dystonia. After a corticospinal injury, the reticulospinal tract may take over voluntary control, but in a crude way, leading to stereotyped movement patterns and proximal joint synergies. Co-contraction can be helpful as a compensation strategy, but in developmental conditions like spastic CP, abnormal co-contraction interferes with function. Now we can discuss the functional impact of upper motor neuron lesions by condition. First, we'll start with stroke. So stroke usually affects the adult brain. The main activity limiters are weakness and loss of selective motor control. Contracture and hyperreflexia contribute to less functional limitation than often assumed. Spinal cord injury comes in two different forms. You have complete and incomplete. Complete spinal cord injury results in paralysis of a certain area of the body, depending on where the lesion is. An incomplete spinal cord injury can cause weakness and poor selective control. Spasticity can also sometimes help with transfers, but severe spasticity can interfere with function. We've all heard of spastic cerebral palsy in the last few chapters. So this is a developmental disorder with abnormal corticospinal development and abnormal muscle growth. Primary problems here are going to be weakness, poor selective motor control, pathologic co-contraction, contracture, and reduced muscle bulk. Interestingly, spasticity severity does not strongly correlate with gait dysfunction. So how do we measure what our functional limitations are? You can use surface EMGs to help determine whether there are limitations due to contractures, hyperreflexias, abnormal timing, or co-contraction. This is important because treatment should match the mechanism, not just the tone score. So it should be important to figure out why we're having limitations. Some intervention implications due to all of this. After a stroke, we have specific approaches that we try to use. Some effective approaches include task-specific practice, strength training, robotic and virtual reality training, and constraint-induced therapy. Using only tone reduction approaches, like traditional NDT, are not supported by strong evidence anymore, but you may still see them out there. So it's important to stay up to date on what is still relevant and what is research-based. For spinal cord injury, we use activity-based therapy and treadmill training to try to activate spinal stepping networks. Functional electrical stimulation can try to restore or substitute for movement. And baclofen will reduce hyperreflexia, but may also reduce useful function. So it depends on how you're using it. Spastic CP, one of the primary drivers of function are weakness and poor selective control. So strengthening does not worsen spasticity, and tone reduction approaches alone are not going to be effective for improving gait. So we have to find some other mechanisms to do that. Stretching does not prevent contraction in neurological conditions. Medications like baclofen, tizanidine, and dantrolene may reduce reflex activity, but not make any muscle structural changes. ALS is going to be a mixture of upper motor neuron and lower motor neuron disorders. So it causes combined upper motor neuron and lower motor neuron signs, including weakness, hyperreflexia, atrophy, fasciculations, and hypotonia. To wrap it all up, upper motor neurons shape movement through multiple descending pathways. The lateral corticospinal tract enables a selective voluntary control, while medial and nonspecific systems regulate posture and overall excitability. Upper motor neuron injury leads to weakness, loss of selective control, abnormal reflexes, spasticity, and coordination problems. Understanding the underlying mechanism, weakness, contracture, hyperreflexia, or abnormal coordination, is critical for choosing effective interventions for these. That's all I have for today. Thank you guys for taking a listen.